Our next speaker is here to talk about the transformational power of investing in children's health. Please give a warm welcome to Dr. Larry Moss, President and CEO of Nemours Children's Health System, one of the largest integrated children's health systems in the country. A pediatric surgeon, medical researcher, and hospital executive, Dr. Moss was previously Surgeon-in-Chief at Nationwide Children's Hospital in Ohio, and he has been internationally recognized for his academic excellence and leadership in healthcare quality and safety. Thank you for being with us today, Dr. Larry Moss.
This is Kayla. See that smile? She just received her master's degree in education, and soon she'll be living her dream, teaching kids from underprivileged neighborhoods. What makes this story special is that when I first met Kayla 27 years ago, she was clinically dead. It's January 1991, a bitterly cold night in Chicago. I'm a young, overconfident surgeon, one of the pioneers of a new therapy called ECMO, designed to save babies with respiratory failure who would otherwise die. When the helicopter arrived, baby Kayla's heart was no longer beating. It stopped about 10 minutes ago. She had about a 1 in 10,000 chance of surviving, but she did. We saved her. I can remember to this moment the look on Kayla's mother's face when I said, she's alive. She might make it. Would have been great to savor that moment, right? My pager goes off. I look down. 13-year-old male, GSW, gunshot wound to the head. I race to the ER and I round the corner and there's a huge crowd of people and I instantly spot the mother. Unlike Kayla's mother, who had a face filled with hope and optimism, Jamal's mother, this mother, had a look of utter resignation, as if she knew this day was coming. I didn't fully understand until I again found myself delivering news. This time it was bad news. Jamal did not survive. Clinically, he died from a gunshot wound, but his mother corrected me. My son Jamal, died of asthma. I still don't fully understand. She explains. Jamal was a smart, creative kid, one of the very best in his second grade class. Then his asthma flared up. He had visits almost every week to the ER, multiple hospital admissions, missed school, his grades slipped. He fell in with a bad crowd. Though his mother worked 2 jobs, she didn't have reliable access to medical care. She had other concerns like paying the rent and putting food on the table. This is when Jamal's easily manageable condition went unmanaged. Led to a downward spiral, which ended while he was still just a kid in gang life. It was a bullet from a rival gang member's gun that ended Jamal's life, but it was asthma that killed him. So Kayla lives and Jamal dies because the best medical care system in the world for a tiny few can also be the worst healthcare system in the world for all the rest of us. So what can we do about Kayla and Jamal? We need to be able to save them both. The people that can do that are in this room today, which is why I'm here to talk to you. Good afternoon. My name is Larry Moss. I'm the president and CEO of the Nemours Children's Health System. Nemours is a multiple state, multiple hospital pediatric system of care. We take care of almost 2 million kids a year in 6 states. Nemours is committed to fundamentally changing the way America cares for kids. Nemours believes that investing in children's health to a greater degree and also in a profoundly different way is the most powerful lever we have to create the healthiest generation of Americans in history and also to create a robust and thriving US economy. As the CEO of Nemours, I get out of bed every day with enthusiasm about 3 goals: to raise awareness of the power of investing in children's health, to transform the way America pays for health care in kids, and to fundamentally change the meaning of health to something bigger and more expansive and more needed and wanted by our families. So in this country, we spend about $3.5 trillion a year on health care. Virtually every penny goes to paying for the opposite of what we want, which is health. We don't pay for health. We pay for volume and complexity of medical service. Volume and complexity of medical service. And we are getting exactly what we're paying for. Compared to the other 33 countries in the OECD, the United States does more than double the number of MRI and CT scans per person than our peer countries. Our per capita rate for some common surgical procedures like tonsillectomy, coronary bypass, hip replacement, over 40% higher than our peers with absolutely no evidence that the disease burden differs between countries. However, of these 34 countries, the US ranks in the bottom 10 in life expectancy, infant mortality, and the management of asthma and diabetes. A young woman is more likely to die in childbirth in America than virtually any other developed country on the planet. We're getting exactly what we're paying for. In this country, we tend to equate health with medical care. The reality is that medical care accounts for a relatively small fraction of health. Most of the evidence suggests around 15%. The other 85%, due to multiple factors that make up our lives, like education, food security, freedom from poverty, avoidance of adverse childhood experiences, and others. The degree of impact of these factors dwarfs the impact of medical care for everyone but a tiny few of us with rare and highly complex medical diseases. For all the rest of us, health is mostly about these other things. So Kayla lives, Jamal dies. There are many social determinants of health, and there's a mountain of evidence that they profoundly impact our outcomes. I'm going to pick a couple of examples: education and adverse childhood experiences. So consider the impact of a few health-promoting behaviors on the length of our lives. Get your pap smear and your mammogram every year. Buys you a couple months on an aggregated population basis. Control your blood pressure. Control your cholesterol. About a year each. Don't smoke, ever. 6 years, 6 quality-adjusted life years. Stay in school beyond high school. Adds 12 years to your life expectancy. So, what do we do about this? What about adverse childhood experiences? ACEs. ACEs are things like physical and emotional violence, incarceration of a parent, substance abuse in the home. 15% of people in this country have 4 or more of these by the time they finish childhood. When these kids grow up, they're twice as likely to smoke. They're 7 times as likely to be alcoholics. They have double the incidence of cancer and heart disease. We think of adult problems like cancer and heart disease as related to medical care. Largely, they're not. They're preventable by investing in the well-being of children. So we've established that these social determinants can have a profound impact on our lives, and this impact can occur over a lifetime. Is there anything we can do about this? The interventions work? Yes. Yes, they do. They work incredibly well. Rigorous, peer-reviewed scientific evidence proves that simple interventions in childhood that are targeted at the right things can profoundly influence the rest of our lives. There's a ton of examples, but let me pick one. The Abecedarian Preschool Project. This project involves the work of James Heckman, the Nobel Prize-winning economist from the University of Chicago. The Abecedarian Preschool Project is a controlled, randomized experiment. Children from birth to age 5 were divided into 2 groups. The study group received 2 meals a day and a healthy snack, periodic medical checkups, primary pediatric care, and some basic information on healthy behaviors and lifestyles targeted to a 5-year-old. The control group went to the same preschool as everybody else. These kids were followed into adulthood. 30 years later, their health outcomes were compared. The kids who received these basic interventions when they grew up had a statistically lower incidence of high blood pressure. They had a 0% incidence of deadly metabolic syndrome compared to 25% in the control group. And they had a markedly lower incidence of morbid obesity. The economic outcomes were equally impressive. Kids who received these interventions, higher high school graduation rate, less likely to be convicted of a crime or incarcerated, and a much higher median annual income. An exciting and unexpected finding was that there was actually a two-generation effect. So people in this study, many people in this study, were in it long enough that they grew up and had kids of their own. The investigators found that they were raising their own kids with the same effective advantage that they received as study participants at absolutely no cost to society. So can a children's health system lead interventions that impact the social determinants of health? I'd suggest to you not only can we, but we absolutely must. Let me tell you about a pilot project at Nemours Children's Health System a few years ago. In 2012, we received a $3.7 million federal grant from the Center for Medicare and Medicaid Innovation. Our goal was to determine if a population-based approach to asthma care, in contrast to a medical intervention-based approach, could change the health of a population of kids with asthma. It was a two-pronged approach, patient-based and community-based. At the patient level, we began with a fundamental mindset shift that our patients, the definition of our patients meant every kid in our population with asthma all the time, not just the ones that came to the hospital at the time they had a complication. We instituted a number of home and family-based interventions. This included care coordinators and community health workers and a myriad of other interventions. At the community level, we focused on environmental and societal factors outside the home which could potentially impact the disease. The results at 3 years, remarkable. We saw a 60% drop in the population-based incidence of visits to the ER for asthma. Remember, this is the aspect of the system that failed Jamal. We saw a 44% decline in hospital admissions for asthma. At the community level, let me give you a couple examples. It turned out that the only metered dose inhalers for bronchodilators on the state Medicaid formulary didn't have indicators, so you couldn't tell when they were empty. So kids had an asthma flare, parents did exactly what they were told, gave the inhaler, they didn't know it was empty. Countless visits to the ER and hospital admissions. So we got the formulary changed. For 13,000 kids, now the inhalers work. An astute community health worker noticed that when the school buses were waiting for the kids outside a Grade school and middle school, they were idling with their engines running. Bus exhaust is a huge trigger for asthma. Talk to the school district. Turn the engines off. 25,000 kids are breathing easier. So we learned 3 important lessons from implementing a population-based strategy in a fee-for-service world. Number 1, these interventions work. When you invest in health, you get health. Simple, inexpensive interventions that are targeted at the social determinants of health can make an enormous impact. For example, the entire cost of the Abecedarian preschool project for 280 kids, $67,000. Less than the cost of taking care of one adult in the hospital with a heart attack. Second, partnerships are absolutely critical. Nemours is a children's health system. We're experts at delivering complex medical care. We are not experts in education, food security, freedom from violence. We need partners who are experts. We need to be the conveners of these experts. In this way, children's health systems and children's hospitals have the opportunity to become the stewards of children's health in American society. Third, in a fee-for-service world, these efforts are not sustainable or scalable. In the current environment, every dollar a health system spends on social determinants of health is a direct cost. It comes directly off the bottom line. And the irony is, the better the intervention works, the bigger the hit to the health system financially. So our families have a huge incentive to keep their kids out of the hospital. We believe children's health systems should too. At Nemours, we're preparing to take full financial risk for every child that we see. At the root of this is our formation and our investment in the Value-Based Service Organization, or VBSO. And some of the brainpower behind that is in the audience today. The fundamental principles of the VBSO involve 3 things: people, process, and technology. With respect to people, we've taken all members of the team who can influence the patient care and put them under one roof with aligned incentives. So doctors, nurses, the finance team, care coordinators, pharmacists, all together under a single reporting structure. To take a complicated health system from a fee-for-service world to a pay-for-health world requires a fundamental cultural transformation. We don't believe you can mandate culture, but we believe that the correct structure enables culture. With respect to process, it's the mindset shift that I referenced earlier on the asthma project. It's changing your mindset from our patients mean our patients on our clinic list or our patients on our inpatient census to our patients is every kid in our population, and we've got a responsibility and an accountability to all of them. Finally, technology. Our use of technology involves using data and numbers to influence human attention. Example, we can use data sets to identify a group of kids who are readmitted to the hospital. A different data set will tell us which kids fall out of the criteria for medical complexity. By crossing these 2 data sets where the Venn diagram intersects, we can target our attention to a group of kids who were readmitted, and it's less likely due to a medical problem and more likely due to a social problem or some other issue where we can intervene and use technology to help us. So in this country, we are absolute experts in caring for the Kaylas of the world. But I propose to you that we could save both the Kaylas and the Jamals. This will require all of us in healthcare to think differently about our responsibility to our patients. It'll require us leadership on our part to redefine health to something that's bigger and closer to what patients and families want. We'll also need to develop, accept, and ultimately embrace payment systems where our financial incentives align with the health incentives of our patients. So please accept my sincere gratitude for the opportunity for Nemours to speak to you today. You'll be hearing a lot more from us in the future, but in the meantime, please take a look in your conference bags for the results of a Nemours poll that shows that families want and need much more from us. It's an unacceptable tragedy that the wealthiest nation in the world can't deliver what Jamal needs. The transformational power of investing in children's health is the single greatest opportunity before our society today. Jamal's one little boy. He represents millions. Thank you very much.